My name's Imelda Coyne and I work in Trinity College Dublin. I've taken over as Director of the Trinity Research and Childhood Centre. My background is as a nurse. I was a children's nurse and I worked in Ireland and in the UK. And my area of interest is decision-making for young people, adolescents and young people. So I've done some research in transition, looking at young people's participation in consultations. And recently we finished a trial of an intervention to promote adolescents' participation in consultations with their doctor. Because in actual fact, when we did prior research, we found that young people had quite a good relationship with the nurses, but they found it difficult to talk to their consultant. So that's briefly me. So Anna Luce gave me a very challenging topic. She said, come and be critical of transition, and it's not an easy position to be in because I'm much more comfortable presenting on my research, what I found, what I didn't find, and I'm speaking to a group where there are a lot of people here who have done excellent research in transition. So bear with me while I try to be a bit provocative. And so that's where I come up with the title, Are We Going Down the Rabbit Hole? So also bear with me, there will be pictures of rabbits. If it offends you, I'm sorry, if you've an allergy to rabbits. So I think this is where we are at the moment. We're down the hole. Some of us are not meeting in the hole, but we are down there to a certain extent, some of us that are researching in this area. So I'm not going to go through all the research in this area because there's a huge body of knowledge now which shows that a well-planned transition leads to improved adherence to appointments, improved adolescent and young adult and parent satisfaction, stable or improved disease control, improved relationships with healthcare professionals and promotion of autonomy. An inadequate transition leads to poor clinic attendance, and we have research in this area, loss to follow-up, risk of non-adherence to treatment. And when we were doing our transition project, we had a letter from a young adult with diabetes who said, I'm very glad you're doing this project because when I moved to the adult services, I didn't like it, I didn't engage, and I stopped managing my condition for 3 years, and I didn't realize the harmful effect that would have on me long term. So more needs to be done to improve this situation. So that kind of brings it home when somebody sends a letter to you and you're running a research project. It brings home the reality, what it's like for young people. Increased morbidities, increased hospital and emergency admissions, and adverse outcomes. So when I went down the rabbit hole to prepare this presentation, here is what I learned. And some of it, there may be gaps in some of this talk, but I welcome you to discuss this critically with me over coffee later. But it could be hard to see this. Sorry, there's a lot here. Basically what I did a smash and grab, which was I wanted to see, are there any systematic reviews published recently in this area? Because there's been very good ones in the past. And I found up to 22 systematic reviews. So Mitchell looked at transition for patients with cerebral palsy and found 27 studies. Lack of transition preparedness, difficulty navigating the adult system, gaps, limited accessibility. Medford looked at young people with disabilities, found 51 studies. Again, the timing and preparation for transition was inadequate. There were issues that they didn't deal with, which was advocacy, autonomy, young people's rights, etc. Lynch-Milder found 8 studies and concluded that there was no published protocols, guidelines or assessment measures in relation to transition for those with chronic pain. And they argued that a lot of people with chronic conditions experience chronic pain, but yet there's very little in this area. Huckerby in 2023, they're all 23 studies, most of them, 14 studies. None looked specifically into core components of effective transitional care for young people with chronic pain. Ghost-link transition in epilepsy, 36 studies. Transition plans or programs were not existing or not adapted to subgroups with intellectual disability or other neurodevelopmental conditions. Evidence limited. So this is just a flavour of systematic reviews of studies that are out there which continue to report problems. And, you know, it's interesting that they all have a different amount of studies because they're coming from different angles. Some are choosing a time span and others are not. But this is just a few from 2023. We also have a systematic review of systematic reviews. And they found 37 reviews of 71 primary studies. And they found that type 1 diabetes was the most common researched condition in relation to transition. And it was 24 of the 71 primary studies. Efforts were targeted at transition preparation, but only 14 of them focused on care after transfer to adult care. And there was a lack of papers on transition in primary care settings. So there's kind of a focus on transition to the acute care in adult care rather than looking at primary care or community care, which is odd when you think, when you look at all the reports in healthcare, how health is changing, how the focus is changing away from tertiary centres to community care provision, moving away from these enormous hospitals to more care in the community. So that's odd that this is continuing here. So that's why I would argue we're still in a rabbit hole to a certain extent. So other studies, too many to mention, and probably many of you know this already, they report abrupt, unplanned transfers to adult services, lack of confidence in the adult services expressed by the young people moving and the paediatric care providers, structural problems that prevent reliable transfer of medical records, because in some systems they don't have electronic patient records, they just have a letter that might come. Lack of opportunities for young people to see the clinicians independently without their parents. Inadequate communication between the specialists. Insufficient coordination of health services. Lack of education and training of healthcare providers. Insufficient flexible services, failing to be responsive to or aware of the adolescents. Insufficient coordination with adult services, failure to include adolescents in transition programs that are meaningful to them. So hopefully by the end of it you'll be so depressed you'll welcome the next talk. No. You know, this is the reality, so we cannot ignore it. So moving on, that's the situation. Have we identified what are the elements of transition? What is it that we mean by transition? So Cecily Betts' paper in 2021, she concluded that despite 3 decades of evidence, there remains a lack of consensus about what constitutes elements of healthcare transition, and the boundaries have yet to be clearly and succinctly delineated. So I looked to see, was there any concept analysis of transition or attempts, and luckily found a review done by Seidel in 2023. I thought, oh good, somebody has attempted to look at the research in this area, so it's going to save me a lot of time. And she found, him or she, I don't know this person, 14 articles, and the attributes were empowerment, a comprehensive process, and transfer completion. And the outcomes were growth, independence, and improved quality of life and health outcomes. And I found that fascinating There's no mention there of self-efficacy, self-management, preparedness. I just thought, is that really what transition is? So I didn't find that very helpful. So moving on from that, I thought, well, maybe we can get an idea of who we're trying to help. Maybe I'll be on firmer footing here. So I looked at the International Association for Adolescent Health, which is a great organisation which aims to promote the health, development, and well-being of 10 to 24-year-olds in every region globally. And then I looked at the SAM, Society of Adolescent Health and Medicine, and they just said it's optimal health and well-being of all adolescents and young adults. So I couldn't find an age anywhere on their website or their materials. I'm a member of that organisation, by the way, both of them. And then the WHO came out with the Adolescent-Friendly Health Service, and they defined it 10 to 19. And then in the UK, they established You're Welcome, which is youth-friendly health and care services, which was a big report policy by the UK government, and they said it's 10 to 24. So are we talking about 10 to 24 when we talk about transition? Are we talking about 10 to 18? Because if we look at the health services, some hospitals have a policy that the young person reaches 18, then they're shunted to the adult services. Others have it that they're shunted around 18. Others hold on to them if they're unstable. And when I talked to some of the doctors about this in one of our hospitals, they said, we don't really say too much about it because otherwise people wouldn't be happy, but we keep them here. We're minding them till they're better. And I said, up to what age? Well, maybe 20, 21, but we keep it under the radar because the hospital has a policy that at 16 they're discharged to the adult services. So this is what's going on underneath. But who are we talking about when we're talking about transition? So moving on, I thought I couldn't get a clear answer there, so I thought, who is responsible for transition? So luckily, all these brilliant publications, a systematic review of systematic reviews, the creme de la creme, would tell me which professionals should be involved in healthcare transition. I thought they did a systematic review of systematic reviews, which did reviews of many studies. 17 reviews, and they concluded that it was a healthcare professional was the key caregiver in all reviews. And members of a healthcare team were nurses, social workers, and peers and mentors. So I thought, where are the doctors in this? They have huge influence. Who are these peers and mentors? I haven't come across them. And who is the professional key caregiver? There was no consistency. Then I found this other review, a systematic review of 47 studies by Doucet. I thought, perfect. And they concluded that most favour health service providers and do not regularly include non-clinical social services and educational team members. So where is the interdisciplinary team there in transition? It seems to be absent. Is it falling on the shoulders of one nurse who is really good at her job? And when she moves on, it falls apart. Because we had very good transition programs, and they fell apart when the key person left, the advanced nurse practitioner. Reliant on one person, but surely it's an interdisciplinary team effort. So I moved on. What can make it better? I thought firmer footing again, because there's a lot in this area. I found 1, 2, 3, 4, just in the last year, of reviews. 14 studies, 12 studies, 29 studies, 36 studies. And Zerzinski said none reported model implementation outcomes such as acceptability, adoption, and appropriateness. So was it acceptable to the young people? How was it adopted? Was it appropriate? Wiles found 12 studies, but they were all different transition models. The models were tailored specifically for kidney transplant recipients were lacking because they were looking at kidney. CORE found 29 studies and noted a lack of educational theory in the intervention design, lack of patient stakeholder involvement, and that's a key issue. Identifying best way to measure efficacy was absent. And Gosling found 36 studies and concluded the evidence is limited. There are significant gaps in knowledge of what efficacious transition constitutes. And these are all systematic reviews of studies. So we still don't know what can make transition better, I would argue. But you can challenge me on that later. So this is a good review by Doucet, and they very helpfully, when they looked at the studies, they identified the barriers to transition interventions working was financial support and lack of training for care providers. The enablers were a dedicated transition coordinator, collaborative care, transition tools, and interpersonal support were the most common enablers. There's a few things missing from that there. I was surprised, 47 papers, and those were the enablers. Was there surely more enablers? The most common patient-level outcome was satisfaction. That's very vague. Are you very satisfied? Yeah, it was great. Who's asking? Because they'll always tell you they're satisfied, the young people. They won't tell you, no, it actually stinks. That's why I don't like coming here. But what I found more interesting about Doucet's review was they said that they rarely tracked the movement of the youth to the adult healthcare, these transition interventions. There was a lack of knowledge among providers, pediatric and adult providers. I think I don't know whether it's different here because, we always think other countries are much better than ours. Well, I definitely do. But when we met with a group of adult providers in Ireland, because we're trying to develop national standards, they lacked so much knowledge of anything to do with transition or young people. It was striking. And there's been many papers published on this from the States, which found that adult providers lack knowledge, but not so much in Ireland. But meeting them, I realized it. Youth and families seldom involved in these transition interventions. That is a huge gap. A lack of policy on transition. Most programs did not include evaluation data and seldom mentioned patient-level outcomes. So what are they measuring when they implement the intervention? So I concluded, and I'm coming to the end of the rabbit hole, that transition programs are inadequately described, different outcomes measured, and weak methodology in some studies when I looked at this area. But there are publications in this area have concluded the exact same. Most of the systematic reviews that I looked at, they concluded that the evidence on the effectiveness of individual transition elements is incomplete. LaRue et al., didn't realize I would meet LaRue et al., so complexity of interventions, multiplicity of outcomes, difficulty of blinding, and the small sample size had consequences for determining the effectiveness of interventions. So it's very hard to know what works. If you're a consultant, a senior doctor, you're running a service, bottom line for many of them, I'm not speaking for people who are here in the audience, but the bottom line as far as I'm concerned is what works? What works? Can you tell me what works? And then we might do it. And Anne Lewis said something very interesting last night. We had a great talk about how the CEO, when she did her project, which was an amazing project 20 years ago, the CEO said, we'll have it all sorted in 5 years. And 20 years later, still making progress. But you can't sort it overnight. So thought I'd cheer you up with a little rabbit after all that news. Emerging from the rabbit hole. We have these two definitions. There's hundreds of definitions of transition. I just picked these two because this one by Blum et al., lovely man, said it's basically a transfer. You're moving them across. And Dovie Pearson Christie, psychologist, Deborah Christie from the UK, they said that it's a purposeful planned process that addresses the medical, psychosocial, educational and vocational needs of adolescents and young adults as they grow up. So which approach do you take? Which approach do you take? Because there's still debate about that. Is it a transfer or are we talking about a lot more? And if it's a transfer, can we do that? I would argue we don't even do the transfer properly. We don't do the transfer. That's the most basic, as far as I'm concerned, is the transfer. Do we transfer them safely to the adult services? Do they attend their first appointment? And there's too much to talk about today, and I'm sure we're going to hear a lot about it later. But when we do research and transition, we're talking to people who are actually there, to young people who are there. When we're tracking them on these transition interventions, we're meeting the ones that attend. We're not meeting the ones that fall off the radar. Or even if they are disengaged, they often don't want to take part in the research. So we're not really. So I don't think we're even getting transfer right, never mind transition. But many of us believe in this. This is the Holy Grail. Should it be the Holy Grail if we can't get the basics right? So what appears to help, I'm not going to go through all of them, but these are some of the issues. Orpin recently did a systematic review. I love all these systematic reviews. It makes my talk easier. Use of digital communication technologies during transition, and found 19 studies and said that, digital technologies were being tried more and more in transition and that they appeared to work. And Bray et al. Did a systematic review in 2022, found 21 studies, and found that co-designed healthcare transition interventions are on the increase and that they work, that they increase the feasibility and acceptability of the transition intervention. 21 studies compared to hundreds and hundreds of other studies. That's a big gap. Many of these interventions have never been co-designed with young people when it's about them. They're developed by somebody and then trialed or implemented. So our areas for improvement are improved integration and coordination across all of these sectors, interdisciplinary team responsibility, knowledge and training. We need a conceptual framework to inform the design and implementation of programs. And Cecily Beth is a member of the Healthcare Transition Research Consortium, and in 2014 they published a model that has all the elements they believe is necessary in transition. But we also have the socio-ecological model by Schwartz-Smart. We also have the GOT 6 core elements of transition from the US. So there is more happening in this area around theoretical development, but there's a lack of consistency. We need better design studies, patient-focused outcomes, and co-design of materials. And I just put a plug in there for the website that we developed when we did our transition project. Because I felt frustrated. I thought you can spend 20 years, I didn't spend 20 years in transition, bear with me, but you can spend 20 to 25 years, as Anne-Lou said, and wonder, do you make a difference? So when we finished this project, we got some extra funding, very small, in Ireland, don't give you much. And we, within 1 year, with only 20,000, we developed a website. We developed 36 pieces of information, developed podcasts, videos, and this was all co-designed with young people who were part of the project, because they said, this is what we would have liked. We don't want to hear from doctors, we don't want to hear from nurses, we want to hear from other young people with this condition who have made the transition. Top tips, what helped them? Kind of practical information. How do you find the clinic? Is there a bank nearby? Can you park, etc.? Can your parent come with you? So, I mean, I've sped through this. I hope I've kept to time. I think I have, is it 10 minutes or 5 minutes? 5. Okay. I just also mentioned, because I forgot to say it earlier, before I move on to planning for the future, Magnus, who's part of the Stepstones project, I don't know whether you've all heard of the Stepstone project, but it's an excellent project. They produce really good papers from it. It's very well designed. And Magnus published a paper in 2021, a process evaluation. One of the points struck me was unmet needs of parents in transition and changing roles. So for me, there's many elements in transition, but there's two things I think that are often ignored. And one is that you need to start early with transition preparation. You need to help them engage in the consultation with their key provider. You need to help them develop their confidence and skills, but you also need to help the parents to slowly relinquish responsibility and help them and support them to develop their skills. And parents have a big unmet need. When we developed the website Resources for Young People, we had a parent advisory group, and they said to me, now, Imelda, you need to develop a website for us. You need to develop videos for us. You need to tell us how do we do it. Because, and hopefully we'll get the paper published, when parents are in the consultation with their young person, they want to portray the image that they're helping, they're supporting, they're good parents. You know, it comes from back years ago, talking about being a good parent, being seen as a good parent. And so they dominate the interaction. So a lot of these young people, even if there is a transition program that's implemented from the top down, or even implemented from the bottom up, if it doesn't address these issues around disengagement and taking on more responsibility and self-efficacy and self-management skills, and do it over a slow process, over a few clinic appointments, then, you know, they're not really prepared. But, you know, many of them, they don't sink. They start swimming when they go to adult services. It's very tough, but they struggle through and they manage despite how difficult it can be. So I just wanted to mention that. I hope I haven't left anybody out in this talk, because there's a lot of very good research in this area. Now, to leave you with my final message, which is planning for the future. I've come up out of the rabbit hole, but I think we're on the ground as rabbits, maybe, or some of us are beneath the earth, but we're not even thinking of the future. We're still researching the past. And there was a very good report done, sorry, I deleted some of my slides because I thought I'd keep it brief, that said that our health services is operating in this old-fashioned way from the past, and we're not moving quickly enough. So at the moment, we're focused in how do we support the movement, the transition of young people to adult services in hospitals. There's a lack of consideration of community and primary care. But there's also thinking that this is always going to be the situation. I mean, if we were to flip it on its head, and I'll give an example of diabetes, when we did the diabetes project, many of the adolescents didn't want to be there, even the ones that were well maintained. They didn't want these regular appointments. They didn't see a point to it. You know, why are they being dragged in to be surveilled all the time and monitored and all that? Could it be done in a different way? What about, you know, having online consultation, digital tools? It's not going to suit every person. But, you know, other countries are moving ahead to robots, you know, delivering medicines, communicating with the young person, because the healthcare professional is too busy to communicate. You know, so, but where are we going? We need to be much more future-orientated and thinking outside the box that we are in with regards to transition. Thank you.
Thank Thank you very much, Imelda. I think you've set the stage for many of the coming talks and the plenaries, because Stepstones, for example, is going to be explained later on as a program, an exemplary program. You've also mentioned a lot of issues that we will address also during the workshops. Just to tell you that the workshop parental involvement is has the least number of participants, which is kind of exemplary of the fact that we are not really addressing parental needs. But still, we are progressing, and I think you've given us some future suggestions about how we should go forward. I'm sure that a lot of the issues around co-design will also come up in the afternoon when we have the workshop Youth Involvement and your plenary talk. I'm sure you're going to say something about digital information a little bit. No, okay. But I'm going to give the floor to you now, Jan Willem. Thank you very much, Imelda.